I do appreciate the board and the members having me today. And I did have the great privilege of meeting Dr. Vic at our GEMS Innovation Summit last year in Indianapolis that was co-located with the FDIC. And I had an opportunity to talk a little bit about this. And we met afterwards, and she said, I think there is a segue here where we could, intersect these two things. And she couldn't be more right. So today you'll see on this title slide, it does say protecting children, but please look at everything we're talking about today through the lens of all afflicted peoples. This is going to be for adults as well. And this not only applies to minors that are being trafficked either in labor or sex trafficking, but also adults. So it's a very simple premise that I'm going to share with you today. What I have on offer today is a reporting model that can be used both in 911 and in our mobile integrated health units. I see even a greater advantage in the MIH units to move forward with something like this. So let's move to the next slide and I'll explain. So this is the title of a paper that produced, this one happened to be published in the Harvard Public Health Review, but it's the product I created after a gap analysis as a student at the Naval Postgraduate School. I attended that as a firefighter, and I was at the Center for Department of Homeland Security. In an intelligence class, we were offered an assignment to do a gap analysis on something missing in our domains, respective domains. And I said, it's interesting to me that human trafficking is such a buzzword, often misinterpreted, misunderstood concept. But here I am in the Bay Area, San Francisco Bay Area, California. I am recognizing I'm at this geographic intersection, a crossroads of both commerce and travel. And I know that in our own districts that we're having this phenomenon going on all around us, yet as a firefighter, as a paramedic, all of our EMS division has no training on this topic. So after a gap analysis, I created an intelligence paper where I modeled off of FEMA, which they use a terrorism liaison officer model. And I took this to the next level and called it a human trafficking liaison officer, creating a single point of contact for reporting of any suspicious activity we see in the field. So go ahead, please. Next slide. So just to review, I'm sure all of you are quite familiar, but human trafficking, by definition, it's a non-consensual action, and anyone under 18 that is involved in trafficking in any way, whether it be labor or sex, is considered non-consensual. Because a juvenile cannot give consent. It's a crime against a person. There's no physical movement required. A person doesn't need to be moved over borders. That's actually smuggling, which is often conflated. They're not free to leave. They're under some sort of force, fraud, or coercion. Oftentimes a passport is being held, a family member is being threatened. There's some other means of controlling processes that are at play, and it involves both labor or commercial sexual exploitation. Next slide, Doc. In the Bay Area, these are local photos for us, but I'll bet these images might be resonating with your cities and municipalities. The homeless populations are rife with, obviously, with low-level and high-level crime, cartel activity, but oftentimes runaways find themselves in these cities. And so we've recognized that these are truly some of our most vulnerable populations, that they lack advocacy. And we're finding that our mobile integrated health units, we have what's called an ARU, an alternative response unit. We're making contact with these folks again and again and establishing relationships. Sometimes they're confessing to us that they're being trafficked. Sometimes they're asking for help and we're finding ourselves unable to move them forward with law enforcement because they're scared to talk to police. But we found this to be a major concern. The risk factors that are listed here, these are not necessarily going to be immediate criteria for human trafficking, but these risk factors have been found to be the most likely causes. A person who comes from a home that has already been sexually abused, a runaway that maybe their home environment is even worse than living on the streets or under a bridge, a pre-existing mental illness, any marginalized group like the LGBTQ community, any sort of physical or mental disability, and poverty, which might necessitate the need to have an income, even if it's coerced. So those risk factors are things that we consider. So we took this model and said, how can we best educate our firefighters to start to recognize the signs and to understand that maybe there's just a single point during a call where you say, I felt like that person was reaching out to me in some way, trying to make eye contact, trying to whisper to me on the side, trying to give me a hand signal. There's been moments where either we've been on a medical call where there was an unscripted environment, let's say a vehicle accident, and we get the chance to have that person, that victim, or that potential patient separated from the other person they're with, who may be their controller. And we start to have this interaction. At the end of the call, we find ourselves saying, something was wrong, and I don't know what to do with the information. So looking at the statistics just for where I live, what we find is that the most likely demographic to be victimized are women. So the statistics here on this page will show you the poorest 1 billion people in the world are 70% are women. Human trafficking victims worldwide, 70% are women. We find in labor trafficking that it's often more men are labor trafficked, but sex trafficking is predominantly female. Where I live, like I said, at this crossroads, this intersection, we're the third biggest hotspot in the nation. And the big point that I would like to point out here is that the statistics from 2014, a study showed that 88% of trafficked victims reported having had positive contact with healthcare providers. That means at some point they were either spoken to by an EMT, a paramedic in the field, they were seen at a hospital, they were seen by a doctor, and those people had potentially an opportunity at that point to identify that there was a problem taking place. Next slide, doctor. So this is the special thing about EMS and especially about the mobile health, because we on our MIH units established this long-term relationship with some of our folks. A lot of our youth were in the schools, we're in the encampments, and we're on the streets. And we're finding out that these individuals, they're so often in the company of that person that is their controller, that we have this unique opportunity with both this combination of trust and access to potentially make direct contact with individuals, giving them an opportunity to reach out to us for help, potentially. Go ahead to the next. So the HTLO model is very simple. It's free. It's easily replicatable. What we did is we simply designated, in my department, I'm a division chief of medical services in my department. And so I am within the fire department, the person to call. And then we're the first in the nation to create an actual EMS protocol with suspected human trafficking and the HTLO model. So we've designated one of our administrators at the EMSA, at our local EMS agency, and they will take all the calls for the rest of the fire departments within our region. They'll take all the calls for the rest of, sorry, do we have some background there? Sorry. They'll take all the calls for the fire departments in the rest of the region, as well as for our transport provider and our contracted transporters. So this is also, hospitals can call through the EMSA. We now have a way that this reporting mechanism results in a suspicious activity report that goes directly to the Northern California Regional Intelligence Center. That's one of our fusion centers, sponsored by Homeland Security, combining DHS investigations, FBI, fire, police, law enforcement. So when this burden of information, this piece of the puzzle, is too great or too ambiguous to hand over to your local law enforcement, we bypass that completely, take it to the federal level. The Fusion Center can then sort it out, can look into it further. They take the incident number, the location, the patient information, and any tidbit of data that we provide to them, and they splice it together and they find out, is this a person we've seen before? Does this match any other reports that we've received from other parts of the state or country? And they can combine that information together, and then as needed, will then re-involve local law enforcement, but with a more complete picture. So very simple process. We have fusion centers across America. They're accessible and available to all of us, but it's the protocol that began in Alameda County 2 years ago. We've already had reported successes. A battalion chief came to me and said, I'm not quite sure this is what you're talking about, but something happened today and I need to tell you. I took the information he provided. I called it in to a suspicious activity report to our regional intelligence center. And by the next day, literally, they had identified that that was the final missing piece of information, was the address. It was the final missing piece of information that created a bust of a sex trafficking, drug trafficking Mexican cartel that was operating in one of our very quiet residential neighborhoods, right in the middle of my district, and really right under our noses. So the reason I share this with you is because I'm offering an idea to you that is simple to deploy. It is literally cost-free. It's simply a movement of intelligence. There is very limited liability. You don't have to be sure about what you saw. You don't have to be deposed in court to talk about it later. You don't have to even follow up on it. It allows that practitioner, that field clinician, that doc to just share the information and then allow someone else who has a more full and holistic picture to potentially piece it all together. So along with our HTLO method, we also educate all of our firefighters, paramedics, and our ARU team, which involves, on ours, we have one of our Alameda County firefighter EMTs or medics, and then we have a street liaison with, they've got the lived experience, and then we have an advanced care practitioner, and we're working under their scope of practice. So they're all educated on this, and then they can relay information back to me. I share the information and through the reporting mechanism, and then we work on the other end to figure out how we can then identify problems with certainty, potentially get the person out of the situation, and then move them on to other available resources. You can move to the next slide. So I want this to be the takeaway for you. It's just the image of a puzzle piece. All I need for you to think about here is that your field practitioners, if they have a tiny piece of information, it doesn't need to be a whole picture. It doesn't need to be a full narrative. It doesn't need to be legitimized in any other way except a suspicion or an intuition or just a piece of data that doesn't match the rest of the data. It's that simple, and it doesn't require any more responsibility or liability, and it takes 5 minutes to fill out these SARs. So my recommendation is that for your MIH units, you educate them on the basic signs and symptoms of human trafficking, what to look for, and then just identify someone within each of your agencies or at your EMSA level to be that point of contact that can receive and relay the information to the Fusion Center to connect the pieces together. You can move to the next slide, and I think you'll have my contact there. And so I have, that's my email address there and my phone number. And if I can provide you a copy of the protocol, or if you would care to look at that Harvard Public Health Review article, which has got the full layout, there's a full description there. But at this time, I would love to just open the floor to conversation. If you'd like to know more about what we have discovered, what our experiences are, or if you'd like to share your experiences, I would love to hear it.